You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for January 15th, 2021. This week, COVID, left atrial appendage closure, a potential clue in AFib, SGLT2 inhibition, and ARBs. First up is COVID. Again, it's still not a very good situation. Wall Street Journal reported yesterday that we had a record number of deaths in one day, more than 4,000. Now, I look at the Johns Hopkins data page often, and it looks like both the U.S. and California case curves have stopped rising. I hope this is a plateau and possible fall in cases. The big news this week seems to be the emergence of a more infectious variant of the virus. F. Perry Wilson from Yale has a nice explainer on why a more infectious virus is so bad, even worse than an emergence of a more deadly strain of virus. It all gets down to math and exponential growth. Even though the chance of dying from the virus is low, say 0.5%, a more infectious strain is so bad because it exponentially raises the number of people infected, and that means you're multiplying 0.5% death rate by a much larger, exponentially larger number. All this raises the stakes for improving the logistics of vaccination. Stories coming out of how well Israel has rolled out the vaccine are really inspiring. There will be many compelling stories written about COVID, and one was sure to be how the bloated and sclerotic bureaucracy that underpins much of U.S. healthcare costs lives by delaying vaccine rollouts to the most vulnerable people. First topic today is about left atrial appendage closure. Now, the use of percutaneous left atrial appendage closure is supposed to be a stroke prevention strategy that avoids the need for long-term anticoagulation. Now, the current study question was to compare left atrial appendage closure with Abbott's Amulet device to direct-acting oral anticoagulants, or DOACs. Now, this would be a very easy thing to study if there was a will to do it. All you need to do is randomize patients to either arm and follow them for stroke or systemic embolism. But that is not what the study authors did. Instead, these authors took about 1,000 patients who had successful implants of this Amulet device and compared them to 1,000 patients from a Danish registry who received DOACs. JACC Interventions published this paper. It's non-randomized comparison, and it yielded truly unbelievable results. The primary composite outcome of ischemic stroke and bleeding and all-cause mortality strongly favored left atrial appendage occlusion. 14% in the device arm had an event versus 26% in the DOAC arm. Pause on that for a second. These authors and this journal wants us to believe that left atrial appendage closure resulted in a 12% absolute risk reduction in heart events. Now, a review of the components of the primary endpoint exposes the obvious selection bias. There were no differences in ischemic strokes. There were a 42% reduction in bleeding and a whopping 47% reduction in all-cause death. The authors concluded that left atrial appendage closure in comparison with DOACs may have similar stroke prevention efficacy, but lower risk of major bleeding and mortality. It sounds great, doesn't it? The editorial is led with this title, quote, "Moving the needle forward for more relevant evidence on left atrial appendage occlusion." The lead investigator told a journalist from MD Edge, quote, "The results suggest left atrial appendage closure to be superior to DOACs in AF patients who have a predicted high risk of stroke and bleeding and adds to the evidence that left atrial appendage closure is a promising stroke prevention strategy in selected AF patients. Okay, I'm going to need to take a couple deep breaths before I tell you all that is wrong with this extremely low quality study. Not only is it non-randomized, but the left atrial appendage closure data comes from an industry-sponsored post-market surveillance study. Unlike, say, an STS valve registry, which is mandated by law, this is likely a voluntary registry. I found this in the protocol from clinicaltrials.gov. Quote, "The principal investigator is responsible for screening potential subjects to determine subject eligibility for the study." My friends, be on alert. These industry-sponsored registries that enroll patients at the discretion of the enthusiast doing the procedure cannot be used for comparisons, period. Second problem, propensity matching, especially across countries, cannot be used to replace randomization. How can I tell there is obvious selection bias in this study? Look at the mortality curves in the paper. All-cause mortality, the curves separate within 3 months. Not even the most enthusiast for this procedure will claim that you can see all-cause mortality advantage in 3 to 6 months. What's more, without a reduction of stroke events, the only way this procedure reduces death is by reducing bleeding. And the bleeding curves don't separate for more than 12 months, and reduction in death was greater than the reduction in bleeding. And if that isn't enough, the most serious and immediately deadly kind of bleeding, that bleeding due to intracranial hemorrhage, was actually higher in the left atrial appendage closure arm, 10 versus 8 ICHs respectively. Of course, patients in the left atrial appendage closure arm were healthier patients, and that is why they did better. Now, there is one positive about this publication. If you are a learner, you can save it and put it in a file as an example of how non-randomized comparisons can be fatally flawed. And finally, do not mistake my critique of this as personal. This is not personal. My concern is that this paper will sit in the literature, be cited by proponents, maybe even incorporated in systematic reviews, and those who take only a cursory look at the manuscript will be misled. And I realize there are some who would say, look, Mandrola, we don't have a lot of data on the matter of left atrial appendage closure versus direct-acting oral anticoagulants, so at least this paper is something. But I would answer that by saying, in the strongest terms possible, if this is the kind of data you cite, then no data is better. This paper should not have been published. Next topic, AF suppression. Jack published a super interesting sham-controlled RCT looking at post-cardiac surgery AF. Now I know what you may be thinking. Super interesting and post-op AFib hardly go together. But the thing that is intriguing here is a potential clue about AF mechanisms. Remember, literally no one understands the exact underlying pathophysiology of AF. And of course, this is why ablation outcomes are so modest. Now here's what the authors did. They randomized about 200 patients who were having a CABG to injection of calcium chloride to each of the 4 ganglionic plexus adjacent to the PV ostia in the LA, or to a sham injection. Calcium chloride injections basically shuts down the autonomic activity. The primary endpoint was postoperative atrial fib, and it was reduced by a lot. Post-cardiac surgery incidence was reduced from 36% in the sham arm to 15% in the active arm. Hazard ratio was 0.36, highly significant. Now, heart rate variability data showed a decrease in both high-frequency and low-frequency power in the calcium chloride group, with a preserved low-frequency, high-frequency ratio, and this suggests that the sympathetic-parasympathetic balance was not perturbed by the injection. In other words, the calcium chloride injection created neuromodulation of the heart. Now, this is obviously just a single-center proof-of-concept study, but it's sham-controlled. I highlight this manuscript not so much because reducing post-cardiac surgery AFib is that big a deal, though it's not nothing. I highlight it because it makes you wonder about the role of neuropathophysiology as an underlying mechanism and possible therapeutic target for AFib. Recall that both sympathetic and parasympathetic neural trafficking in the atrial autonomic neural network is processed and integrated through these GPs, ganglionic plexi. Previous data, as the authors discuss in their paper, is mixed and confusing. Ablating the GPs at the time of PVI, for instance, has been tried and the results are unclear, perhaps because of mixing of patients or the inclusion of patients with super sick atria. But all of us ablationists have seen patients after pulmonary vein isolation who report slightly higher resting heart rates. This is surely due to neuromodulation of ablation. This seems to associate with success. And cardio-neuroablation is undergoing a resurgence of interest, and I really wonder if there isn't something here. This study is a clue, a small clue. If this is a real finding, it should be easy to replicate in multi-center studies. And if it reduces post-op AFib by that much, it will be a big gain in societal cost. But I think its biggest gain may be that it's a clue to the mysterious underlying physiology of atrial fibrillation. Next topic are SGLT2 inhibitors. As a class, the drugs have pretty amazing cardiovascular renal outcomes data, but they cost a lot. High cost raises the question of patient selection. So a group of authors report on the application of a biomarker-based score to identify individuals with dysglycemia who are at high risk for incident heart failure. The author's goal is to gather info on better allocation of the drug. Now, they used 3 longitudinal cohorts to do this study, the ERIC, Dallas Heart Study, and MESA studies. Their risk score was integer-based, like the CHADS FAST score, and it included high-sensitivity troponin, NT-BNP, CRP, and, interestingly, LVH by ECG. And there was just 1 point per category, so 0 to 4. They then estimated the risk of developing heart failure across the risk categories. Their final cohort was about 7,000 patients. Listen to this. 1/3 had diabetes and 2/3 had pre-diabetes. That's interesting that the majority of patients in this study did not even yet have overt diabetes. The 5-year risk of heart failure among subjects with the biomarker score of less than 1 was super low and comparable to patients with euglycemia. But heart failure increased in a graded fashion with an increasing biomarker score. In the paper, there's a nice picture displaying the different odds by risk category. They used the score of 0 as the reference. And so 1 point had an odds ratio of 1.8. If your risk score was 2 points, your odds of developing heart failure was 2.4. And if your score was 3 to 4, your odds ratio of developing heart failure in the next 5 years was 4.7. The same sort of pattern was seen in patients with prediabetes. So if you use the drug in all patients, they estimated that you would prevent heart failure events, say 11 out of 1,000 over 5 years. But if you use the drug in patients with a higher risk by this integer score, you prevent even more events, say 44 out of 1,000 patients treated. Now, an important distinction in this data is that none of these patients had any heart disease. I also think it's notable that they included patients with prediabetes and found a 16-fold gradient of 5-year risk across increasing scores based on these risk factors and biomarkers. Now, obviously, this is a statistically complicated study using point measures of biomarkers that could easily change over time. What's more, you'd want to validate this approach in trials. But the fact remains that SGLT2 inhibitor uptake in patients with diabetes is low, probably due to cost. As an EP doctor, I see tons of patients with AFib who either have prediabetes or diabetes and they have risk factors for heart failure, say obesity, hypertension, sleep apnea, chronic kidney disease. When these patients are on diabetes meds other than SGLT2 inhibitor, my mind starts churning. Why are we not using a class of drugs that induce weight loss, renal protection, real renal protection, and reduced heart failure events? In an ideal world, we would have no need for risk scores of beneficial drugs. We could just use them in everybody. But the fact is that in cost-constrained systems, risk stratification remains important. So this is an interesting approach. And I have a soft spot for biomarkers and ECG risk scores. Okay, final comment. I feel a little bit over my skis here talking about diabetes medicines. It's extremely likely that the majority of people who listen to this podcast have more experience using these drugs than I do. So, I seek your input. Send me a note in the comments on the heart.org Medscape Cardiology or on Twitter. I'm actively trying to learn more about treating patients with diabetes. Final topic is ARBs in chronic kidney disease. Now, one of the things I see all too often is the reflex to stop ACE and ARBs in patients with chronic kidney disease. The creatinine goes up just a little bit and boom, this is it for a beneficial class of drugs. What's interesting is that my nephrology mentors at IU warned against this strategy back in the 1990s, but it persists to this day. Of course, guidelines recommend making this decision on a case-by-case basis, but doctors are risk-averse, so the creatinine goes up and boom, it's just so much easier to stop the drugs. The study from Swedish, Dutch, and Canadian authors looked at the association of outcomes in patients who did or did not stop RAS inhibition in patients with advanced CKD. They used a Swedish renal registry of patients over a 10-year period. These were patients who developed CKD with an estimated GFR less than 30 while taking RAS blockade. They had about 10,000 patients in this category, and 15% stopped the RAS inhibitors. So the two non-randomized comparison arms were patients who stopped RAS inhibition versus those that didn't stop RAS inhibition. And compared with continuing RAS inhibition, stopping therapy was associated with a 14% higher 5-year risk of death and a 12% higher risk of MACE, but an 8% lower risk of kidney replacement therapy. Now, the problem, of course, is sorting through this non-randomized comparison. You have to look for confounding variables. Were the patients who stopped ACE and ARBs sicker, and that is why they fared worse? I suspect strongly that this was the case. Again, the clue is that the mortality reduction is larger in absolute terms than the reduction in MACE. So we won't make any causal inferences, nor will we cite the study to make any clinical rules of thumb. We will just say that the routine stopping of RAS inhibition in CKD is unwise. Instead, try to continue the drug, but with close follow-up. Clearly, it is harder work to continue the drug than it is to stop it. Also, we learn in the column by journalist Marlene Busco that there is an ongoing RCT called the Stop ACE trial. That's going to study discontinuation or continuation of RAS inhibition in patients with CKD. This is a great development because randomization is really the only way to answer this important clinical question. So I want to conclude by saying that 2 studies came out this week looking at CMR in athletes, one from Vanderbilt and the other from University of Wisconsin-Madison. Look for some comments on that from me next week. So that's it for this week in cardiology. As always, I'm grateful that you listen. Thank you. And remember, please, it really helps if you can take the time to give us a rating, write us a brief comment, even a sentence or two. Tell us what you like, what you don't like. These comments and ratings help others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.